This conference will now be recorded.
Stroke in pregnancy.
This conference will now be recorded.
Stroke in pregnancy, incidence, investigations, and management. Stroke can happen to anyone at any time, even new mothers. Introduction. The term stroke is used to indicate damage to the brain caused by a vascular etiology. Stroke is defined as a neurological deficit attributed to acute focal injury of the central nervous system by a vascular cause, including cerebral infarction, cerebral vein thrombosis, intracranial hemorrhage, and subarachnoid hemorrhage. Strokes can be of two types, hemorrhagic and ischemic. Hemorrhagic stroke occurs when a blood vessel ruptures and tissue is damaged by the resulting spread of blood into the brain parenchyma. Ischemic stroke occurs when blood flows to the brain is impaired and tissue dies. Causes of ischemic stroke include atherosclerotic disease, embolism, thrombi, and hypertension. Why stroke is important? It is the second leading cause of death and third leading cause of adult disability. 1 in 6 people at risk of experiencing a stroke in their lifetime. In people under the age of 20 years and young and middle-aged adults, which are between 20 to 64 years, the proportion affected by stroke is increasing. It is no longer regarded as a disease of old age. It has an incidence of 30 per 100,000 pregnancies. So this is 3 times the incidence in non-pregnant female individuals aged between 15 to 44 years. Most strokes, 90%, they occur peripartum or in the 6 weeks following delivery. Antenatal period incidence of 1.5 per 100,000 deliveries as reported by UCOS. Overall risk of recurrence is 0.5% outside pregnancy, and the risk is up to 1.8% in next pregnancy. The independent risk factors for stroke: maternal age more than 35 years, migraine, gestational diabetes, preeclampsia or eclampsia, pre-existing hypertension, and a case fatality rate ranging from 8.8% to 20%. In hemorrhagic stroke of pregnancy, it is 13.9%, and in ischemic stroke in pregnancy, the incidence is 3.4%. Residual disability is 50% in hemorrhagic stroke and 33% in ischemic stroke. Intracranial hemorrhage being the single greatest cause of maternal death from stroke. Incidence of pregnancy-associated stroke to be 10.2 per 100,000 deliveries. Most strokes in the general population, they are ischemic, like 80 to 85%, but in pregnancy, ischemic hemorrhage and the venous thrombosis, they have a similar contribution to etiology. 19.9 per 100,000 pregnancies for non-hemorrhagic stroke, both of arterial and the venous thrombosis types, and 12.2 per 100,000 from hemorrhagic stroke. In cerebral venous thrombosis, 12.2 per 100,000 pregnancies. In ischemic stroke, 9.1 in cerebral venous thrombosis, 12.2 in hemorrhagic strokes per 100,000 pregnancies. The risk of cerebral venous thrombosis is increased by the physiological regulations of clotting factors in pregnancy. Pregnancy-specific conditions that further increase the hypercoagulability state include ovarian hyperstimulation syndrome, hyperemesis gravidarum, preeclampsia, prothrombotic medical conditions in pregnancy such as antiphospholipid syndrome, sickle cell disease, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, mechanical heart valves, cardiomyopathies also increase the risk of ischemic stroke. Hypertensive disorders of pregnancy, including preeclampsia, eclampsia, they increase the risk of hemorrhagic or ischemic stroke and can be associated with posterior reversible encephalopathy syndrome and reversible cerebral vasoconstriction syndrome. Amniotic fluid embolism is a rare pregnancy-specific condition that has been associated with stroke. A stroke is a curable condition with timely intervention. Investigations and management of acute stroke. In acute stroke, time-sensitive thrombolysis and thrombectomy may improve outcome. Clinical presentation, symptoms, and signs of stroke. Stroke is a clinical syndrome characterized by rapidly developing symptoms with signs of focal cerebral loss of function and no cause other than that of a vascular origin. The symptoms and signs relate to the affected area of the brain. While evaluating a patient with stroke, you need to obtain a good history from the patient or witness to identify the timing and sudden nature of onset of the symptoms. The onset of stroke is typically sudden with focal symptoms and clinical deficits conforming to a vascular territory. Depend that which artery has been affected or which vein has been affected. Symptoms include unilateral numbness or weakness of the face, arm, or leg, dysphagia, hemianopia, cerebellar features such as dysarthria and ataxia. Patient can have non-focal symptoms like generalized weakness and or sensory disturbance, lightheadedness, brief loss of consciousness, and urinary or fecal incontinence, confusion, tinnitus. They are less likely to be caused by stroke. CVT is a diagnosis which should not be missed as it can result in both venous ischemic and hemorrhagic infarction. The hemorrhage arises from the venous congestion as a result of backflow of blood from the occlusion of a major sinus. CVT often presents as a severe headache with symptoms of increased intracranial pressure, such as nausea and vomiting. Frequently, papilledema is present on physical examination. CVT can be variable in its clinical presentation, with only 40% of patients presenting with typical stroke symptoms and signs, and like a headache, drowsiness, or confusion. They can also occur with deep pain, occlusion of the thalamus. The FAST campaign, it was created to promote public awareness of the symptoms and signs of the stroke and to encourage rapid response. Subarachnoid hemorrhage is a consequence of the bleed rather than being caused by hypertension itself. Severe intracranial bleeds, they can also be associated with a relative bradycardia. If a hypertensive patient is relatively bradycardic, this may lead to suspicion of an intracranial bleed rather than a stroke. In this picture, you can see that there are different lobes of the brain. This is the frontal lobe, lies towards the forehead, parietal lobes, temporal lobe, and then in the posterior region, there is occipital lobe, and under this area, all of these temporal and the occipital lobe lies the cerebellum, and brainstem lies in the central area of the brain. Clinically, it is difficult to distinguish an intracranial hemorrhage from an ischemic stroke at the bedside. Headache, nausea, vomiting, and a depressed level of consciousness, these are more common in hemorrhagic strokes. Systemic blood pressure tends to be higher in intracranial hemorrhage than in the acute ischemic stroke. A relative bradycardia may also be seen in severe intracranial hemorrhage with associated raised intracranial pressure. Seizures can occur following a stroke. Rule of thumb in pregnancy is that most new onset seizures after 20 weeks of gestation and up to 2 weeks postnatally are caused by eclampsia unless proven otherwise. Importantly, focal neurological deficits are not typical of eclampsia. Basically, visual symptoms they are seen. These include blurring of vision, diplopia, amaurosis fugax, photopsia, scotoma, and homonymous hemianopia. Could be caused by cortical blindness, serous retinal detachment, then Usher-like retinopathy, central retinal vein occlusion, and retinal or vitreous hemorrhages, which may occur as a complication of preeclampsia. Imaging is necessary if there are focal neurological symptoms and signs or visual symptoms persist despite optimization of blood pressure control. History. Specific questions to ask when taking a history. Where were you when you experienced the symptoms of stroke? What were you doing at the time? What did you first notice was wrong? When were you last free of symptoms? Then what happened? The FAST campaign outlining how to recognize symptoms of stroke. F means face drooping, A arm weakness, S speech difficulty, and T time to call. Investigations and management of stroke. A brief history at the time of onset, the symptoms, and pre-morbid status, along with potential contraindications to thrombolysis. This is taken. Scores on the National Institute of Health Stroke Scale and Modified Rankin Scale should be recorded. Here you can see that there can be different symptoms. These scores are based on the level of consciousness, then loss of consciousness, and what was the age, what was the awareness. These are printed forms, and the doctor who is going to assess these patients, they can take, and then the score is calculated. Imaging, it should be done promptly in pregnancy. All patients with suspected acute ischemic strokes, they should have brain imaging on arrival to hospital. Non-contrast CT. In most cases, non-contrast computed tomography, it will provide the necessary information to make decisions about acute management, such as intravenous thrombolysis. Intracranial hemorrhage is a contraindication to thrombolysis. Management is focused at maintaining hemostasis and correction of coagulopathy. Sometimes surgery has to be done if required. CT angiogram. In anticipation of thrombectomy, when a large vessel occlusion is suspected, it is considered better in detecting higher degrees of cerebral arterial stenosis. Safe in pregnancy as less radiation exposure as compared to CT perfusion. Now there is theoretical risk of fetal thyroid suppression, so neonatal thyroid function tests are indicated within first 2 weeks of the birth. CT perfusion, more specific in detecting infarction and ischemia of brain tissue. CT, the most appropriate tool for initial rapid diagnosis and readily accessible when fetal radiation exposure is less than 0.1 VY, not associated with higher risk of adverse events. Combination of CT angiogram and CT perfusion. It offers most accurate assessment of site of occlusion, infant core, and salvageable brain tissue and collateral circulation. MRI is the preferred first-line investigation in pregnancy. It further distinguishes stroke subtypes and vascular imaging. Potential hazards of MRI, like there is theoretical biological damage, tissue heating, and potential damage to the fetal ear. No harmful short or long-term fetal effects at T 1.5 or less. On MRI, white matter lesions are hyperintense on T2 and hypointense on T1. Gadolinium chelate, it may be used to enhance MRI studies. Only 0.01% remains in the fetus after 4 hours, and just traces persist after 24 hours. Well-documented informed consent should be taken, and extreme caution should be taken. Investigations for underlying causes of stroke. These investigations should be carried out in young women. Investigation like 12-lead electrocardiogram if the patient has atrial fibrillation or there is history of cardiac ischemia. 24-hour cardiac Holter monitoring if your patient has history of atrial fibrillation. prolonged cardiac monitor or implantable loop recorded if there is history of paroxysmal atrial fibrillation. Transesophageal echocardiogram if patient is known to have patent foramen ovale. Similarly, we can also offer transthoracic echocardiogram with bubble test if a patient has patent foramen ovale. Full blood counts, urea and electrolyte, liver function test, uric acid, coagulation profile. These all should be done if you are suspecting preeclampsia. Lipid profile, thrombophilia screen, it should be done when you are suspecting preeclampsia. Carotid and the lower limb Dopplers, these should be considered in addition to lipid profile if you are suspecting hypercholesterolemia in your patient. Similarly, these investigations should be carried out if the patient has antiphospholipid syndrome or has some inherited thrombophilias or patient has developed venous thromboembolism. Limited benefit of inherited thrombophilia screening in pregnancy due to hypercoagulable changes in the body. In presence of patent foramen ovale, we carry out these investigations to rule out paroxysmal thromboembolic events. Management of stroke. Time is brain. This approach is adopted. So time sensitive and perfusion therapies, pre-perfusion therapies, they are associated with improved functional outcomes. Intravenous thrombolysis, recombinant tissue plasminogen activator significantly improves overall outcome when administered within 4.5 hours of onset. Risk of hemorrhagic stroke development is 2 to 6%, though it doesn't cross placenta, but theoretical risk of placental bleeding and IUFD, they have been documented. Earlier intervention is proportionally beneficial. There can be certain contraindications to thrombolysis, like we can divide them into absolute contraindications and relative contraindications. Absolute contraindications include intracerebral hemorrhage, suspected subarachnoid hemorrhage even if normal computed CM tomography, neurosurgery, head trauma within the last 3 months, systolic blood pressure more than 185 millimeters of mercury or diastolic blood pressure more than 150 millimeters of mercury. If there is history of intracranial hemorrhage, known intracerebral arteriovenous malformations, neoplasm or aneurysm. Active internal bleeding, suspected confirmed endocarditis, and known bleeding diathesis or platelet count less than 100,000. Heparin has been given within 48 hours or current use of warfarin with or without heparin. Relative contraindications include age more than 80 years and a National Institute of Health stroke scale of score more than 25 and coma. Multilobal infarction or CT, previous stroke within the last 3 months, diabetes mellitus and previous stroke, then minor or rapidly improving stroke. Major surgery or serious non-head trauma within 14 days, gastrointestinal or urinary tract hemorrhage within 21 days. Seizure at stroke onset. Recent arterial puncture at non-compressible site. Recent lumbar puncture, then post-myocardial infarction pericarditis and pregnancy. Post-stroke thrombolysis care is very important. So patient should be on 24 hours of bed rest and may not be essential if the patient is very stable. Maintain oxygen saturation above 95%. Maintain normal temperature and use paracetamol if temperature is more than 37.5 degrees centigrade. Maintain blood glucose level at less than 10 millimoles per liter. Deep bone thrombosis prophylaxis with intermittent pneumatic compression devices should be offered. No arterial lines, nasogastric tubes, or central lines for 24 hours. No urinary catheters until at least 1 hour after infusion ends. Avoid suctioning and careful mouth care. No aspirin, clopidogrel, dipyridamole, or anticoagulants for 24 hours. Repeat CT in 24 to 36 hours. Maintain hydration and nutrition. Risk assessment and prevention of falls. Stop recombinant plasminogen tissue plasminogen activator if neurological deterioration of 2 points on Glasgow I motor scale. So for signs of systemic bleeding and stop recombinant tissue plasminogen activator. Monitor PP, stop plasminogen activator if for more than 5 minutes the systolic PP more than is less than 100 or more than 180 millimeters of mercury and diastolic BP is more than 105. Observe for signs of anaphylaxis and stop recombinant tissue plasminogen activator. Mechanical thrombectomy can be done. Mechanical thrombectomy with stent retriever devices is superior to IV recombinant tissue plasminogen activator alone. Benefits if it is administered within 6 hours of onset of stroke. All eligible patients they should be considered for clot retrieval and urgently referred to higher specialized centers, and it can be done up to 24 hours after stroke. And this referral is appropriate in 10% of cases of acute ischemic strokes. Thrombectomy plus standard care have better outcomes for disability at 90 days as compared to standard care alone. Management of intracranial hemorrhage, hemostasis, correction of coagulopathy, thrombocytopenia, and hyper or hypoglycemia. BP control and VTE prophylaxis. Use anti-epileptic medication to treat seizures. Consider surgical decompression in cerebellar hemorrhage with deteriorating neurological function. Management of cerebral venous thrombosis. Anticoagulation with low molecular weight heparin or unfractionated heparin. If anticoagulation contraindicated or patient doesn't respond, then thrombolysis should be considered. Patients with raised intracranial pressure, they can be treated with IV mannitol and considered for decompressive craniectomy. Management of preeclampsia, eclampsia, and PRES. PRES is posterior reversible encephalopathy syndrome. If preeclampsia is suspected, whole blood counts, liver function test, urea, electrolytes, and uric acid levels they should be checked to rule out HELLP syndrome, which means that patient has hemolysis, elevated liver enzymes, low platelets, or thrombocytopenia. Magnesium sulfate is well documented in treatment of prevention of eclampsia as it raises threshold for seizures and decreases neuroinflammation. PRES is associated with PET, eclampsia, hypertension, infection, sepsis, and shock. Autoimmune disorders, chemotherapy, and massive blood transfusion. Optimize BP by removing or treating suspected causative factors. Deliver the baby in case of PET or eclampsia. Most cases, they resolve on their own within days to weeks. Stroke unit care. Multidisciplinary unit with focused nursing care, specialist medical treatment with specific protocols, coordination of rehabilitation services, and patient education. Patients treated here are more likely to be alive, independently living at their homes at 1 year after stroke. How it affects mother-baby bonding and feeding due to separation of mother and baby. Secondary prevention strategies. Recurrent stroke in 25 to 30% of all strokes. Aggressive BP management is central to secondary prevention. Gradual and sustained lowering of BP is recommended for all stroke patients. Increased maternal mortality with a systolic BP of more than 160 and diastolic BP more than 100 millimeters of mercury, mainly due to intracranial hemorrhage. Aspirin therapy is recommended in acute ischemic syndrome patients within 24 to 48 hours of onset. If patient receiving thrombolysis for 24 hours, then delay aspirin when intracranial hemorrhage has been excluded. In minor stroke or transient ischemic attack, dual antiplatelet therapy like aspirin and clopidogrel, it should be started within 24 hours and continued over next 21 days, as it may be beneficial for early secondary stroke prevention. Should be used cautiously as associated with higher risk of major hemorrhage at 90 days as compared to patients on aspirin alone. Clopidogrel is category B drug. It means that you can administer this drug when the benefit outweighs the risk. Treatment should not be withheld due to pregnancy. It should be stopped 7 to 10 days before a scheduled delivery. If patient goes into spontaneous labor, avoid neuroaxial anesthesia. Patients with androgen with acute ischemic stroke, atrial fibrillation, then initiate oral anticoagulation within 4 to 14 days of onset of neurological symptoms. High-intensity statin therapy should be initiated or continued as first-line therapy in all patients with atherosclerotic cardiovascular disease if no contraindication exists. Smoking cessation is important for part of secondary prevention. And the incidence of patent formal ovale in general population is about 20%. Mode of delivery. Multidisciplinary team input is required, and the team should have specialists from obstetrics, neurology, radiology, neurosurgery, cardiology, anesthesiology, and hematology. Individualized plan should be made according to the condition of the patient. Neonatologist should be informed of the decision. Mode of delivery can be spontaneous delivery, or if there is indication for cesarean section, then it should be carried out in a tertiary care center. Postpartum management. This is the highest risk period for VTE and stroke. Continue anticoagulation for 6 weeks postpartum. Multidisciplinary team care is required. Factor V latent heterozygosity and persistent lupus anticoagulant, they are associated with increased risk of transient ischemic attacks, amaurosis fugax, and ischemic strokes. Full thrombophilia screen at 6 weeks postnatal appointment should be carried out. Breastfeeding is safe if patient is on aspirin, warfarin, or low molecular weight heparin. Contraception. Combined hormonal contraception is contraindicated. Progesterone-only contraception can be considered. Use non-hormonal contraception in preference to hormonal contraception. Preconceptual care. Individualized care for women with prior stroke, and no specific secondary prevention strategies are available, and closely monitor future pregnancies as high risk of recurrence.